medical misinformation is everywhere. Dr. Mitch is here for straight talk and to give you the truth.
Hi everyone and welcome back. Last time we discussed the ridiculousness of depending on a lab test, especially the LDL, to determine particularly a patient's risk of coronary artery disease. I very strongly recommend that you watch the last video to help you through understanding that if you haven't already. Today, we're going to look at some other blood tests that give us, as clinicians, a good idea of the potential of a particular person to actually develop an arterial plaque. And I say arterial plaque because if you ever notice that there is no venous plaquing, wonder why? You should think about that as well. We'll probably break this into two parts just so that we can be as complete as possible. Dr. Mitch Ghen, and thank you so much for visiting this particular video today. So let's talk about some of these cardiovascular disease markers. The first is a combination of apolipoprotein A and its complementary apolipoprotein B. Apolipoprotein A is a structural and functional protein that constitutes approximately 70% of the protein in high-density lipoprotein HDL. It should be greater than 100 milligrams per deciliter. It's, for the most part, protective, except when it wraps around LDL, which is a story for perhaps next week. Apolipoprotein B, on the other hand, hereditary, by the way, is an acute phase reactant. It's increased in infection, inflammation, strenuous activity, smoking. It is a primary protein of the LDL. It is strongly associated with arteriogenesis, meaning it's 4 times more likely in studies to increase or cause plaquing than the actual LDL itself. Now, the C-reactive protein high sensitive is one of the best tests that have ever come out. It is sensitive about inflammation, and it pretty much should be less than 1. Greater than 1 is considered mild inflammation of the arteries, 2 to 3 is considered moderate inflammation, and greater than 3 is considered significant inflammation. Levels greater than 3 suggest more than a 2-time increase in heart attack risk. And levels higher than 5, well, they may represent inflammation elsewhere in the body. I use a high-sensitive C-reactive protein pretty much for every single patient. You'd be surprised how many people have that. And the one thing they've noticed when they did more than 40 determinants of octogenarians, those that lived over 100 years old, was the absence of elevation of inflammation. We know inflammation is pretty much the nidus for pretty much most diseases that kill humankind, especially coronary artery disease, as well as cancer. More on tests that you should be doing next time. And hopefully, if not next, we may have to do 2 or 3 with this. But we're going to complete this to give you a good bunch of things in your armamentarium that you should be doing on everyone to determine the proclivity of developing a plaque in the artery. I'm Dr. Mitch Ghen. Thank you so much for watching.